Hi. Hey, Dr. Kocak, thank you so much for doing this Zoom video in lieu of an IG Live that we just tried, and we were having some connectivity issues, which we can't always predict. So I'm going to welcome everyone today to the Deep Sea Foundation channel, Breast Reconstruction, and I'm joined today by Dr. Ergun Kocak with Midwest Breast and Aesthetic Surgery in Columbus, Ohio. Welcome, Dr. Kocak.
Thank you so much, Terry, for having me. This is a big pleasure. Sorry it didn't quite shake out on the Instagram Live. I'm going to take full credit for that because I'm a bit of a technophobe in a lot of ways, and I don't think I'm quite up to speed on my technology. So I'm sure we'll sort it out, and we'll go back to it when we have it all settled. But I do know how to use Zoom, so we'll make this work here on Zoom, and you can put it up on your social media and wherever else you want to try to spread the word.
Yeah, well, you know what I'm finding out is as we go along, and I think particularly now during the COVID crisis, a lot of us are trying new platforms.
Yeah.
And I have to ask people, well, how do you use this? How do you do that? I can't get this to work. We're all learning this together. So I appreciate your patience and also being able to use this platform to ask you some questions this morning.
Absolutely. Yeah, shoot away. Let's have some fun.
Yeah. So what I'd like to do is start out, the foundation likes to reach out across the globe really and talk to different microsurgeons so that we can give information to patients.
Yeah.
The foundation really is the liaison between the microsurgeons and the patients. What I'd like to ask you just to start out, I've become fascinated with the topic of microsurgery, obviously, but can you tell us about your training and why you went into this particular subset, this particular specialty of plastic surgery?
Well, it's certainly something that I didn't start out in medical school thinking I'd end up doing. When I first got out of medical school, I was in general surgery, and I actually really wanted to be a surgical oncologist. And so I put a lot of energy and effort towards training in surgical oncology. My mother had breast cancer twice, and so that was back when I was in high school and early part of my college. And so that was really influential in sort of steering me in that direction. And I had a lot of awe, sort of really looked up to her general surgeon, who was a breast surgeon. So I think that's what kind of got me going in that direction. And through medical school, I figured I would really want to do that. So I took a general surgery residency, a categorical general surgery position. And I was training as a general surgery resident. And I really wanted to go to one of the big cancer institutions to train for surgical oncology. I really wanted to either go to Sloan Kettering in New York City or MD Anderson in Houston. And so to do that, I realized, as part of my training, I really needed to, and I also had a very strong interest in research. And I knew that research was probably going to be very important to understand, to be able to do it well. And so I knew that during residency, I wanted to spend some time in a laboratory in order to, really begin to understand how research in that area was done. And so I took 3 years out of residency, actually, and I spent it doing clinical and laboratory research, dedicated, completely non-clinical work. I was outside of the residency program doing that stuff, and I did that for 3 years. Ultimately, I planned to do it for 1 year, but it turned into 3 after things kind of ramped up and picked up. We had a lot of success that, you just couldn't leave things on the table. Each year would come to an end, and I had a lot of stuff to finish. So we'd do another year, and then, 1 became 3 very quickly. And ultimately, I got back to my residency, and that time in the lab, I think, gave me a lot of time to grow and sort of reflect on the things that what I could take and what I couldn't tolerate or what I could do. And it became really quickly evident that the surgical oncology world was a little bit tough for me. I was having a hard time with some of the diagnoses and how difficult some of the surgeries. You do these big operations, and sometimes you'd add days to people's lives, maybe not. And so it was very frustrating, and it was and that became very tough for me. And so I really wanted to do something in the cancer arena, but I don't think I had sort of the skin that was thick enough to make it in that area. And I realized quickly that plastic surgery was a great way for me to still be able to do that. And that's why I went into plastic surgery with a very specific desire to be mostly, on the cancer side of reconstruction. And I ended up going to MD Anderson still and did my fellowship, but it was in reconstructive microsurgery instead of surgical oncology. And so that's kind of how I ended up where I am today.
I'm a little breathless right now for a couple of reasons, and I have to tell you why. Your colleagues, so I'm able to talk to them through these conferences that we go to, and it seems like forever since I saw you, and it was only in January.
I know.
At the microsurgical conference. You have a very high reputation for being a researcher and one who's very keen on, publishing papers, writing good papers. Now I know why.
I appreciate it.
But also, Dr. Kocak, I had no idea about this background with you. So I see why you now have a very strong interest in breast cancer. I didn't know that about your mother. And the other thing too is my first diagnosis, I was treated at MD Anderson.
There you go.
It's a great center. And I used to go down to Houston for my treatment. And that's when it was the Pink Palace, I called it, which you probably remember.
Yeah.
It
really was. It was a salmon-colored campus. You're so correct.
Yes, and now they have the whole. Is it Nellie B. Connolly Breast Center there?
It grew so much. I was there in 2008, 7. It's grown so much since we've left. I was down there a few years ago for one of the health systems up here was doing something, and I couldn't even recognize it anymore.
I know it grew. Well, I left Houston. We left Houston in 2008.
Yeah, that's when I was there.
I know.
Just missed you.
I know. That's so crazy. Such a small world. Tell me now, you told us about your background. Tell me now about the services. You're in Columbus, Ohio, and you work with a team there. Tell us about the services that you provide at Midwest Breast and Aesthetic Surgery.
Yeah, it's interesting, actually. So, just what you were saying now about MD Anderson, and obviously MD Anderson and Sloan Kettering, they're premier institutions. They're incredible institutions, and they're huge organizations. And, I think several years ago, this type of complex breast reconstruction, microsurgical breast reconstruction, it was largely limited to these really big institutions. And so when I came out of my fellowship, I actually spent about 5 years working in the academic environment at the James Cancer Hospital up here in Columbus. Okay. And so my partner, Dr. Tawari, also, we were both there as faculty in a university department. And, when you train your whole life in these huge institutions and academic environment, I think we start to think that these types of surgeries really can't really happen anywhere else. But just like with anything, just like when the first computer was built, it took the entire level of a building, right? And now we've got these little phones that sometimes work and don't work, right? But you've got a whole computer. I mean, this phone is stronger than the computer that took an entire level. And so everything advances. And I think as technology has advanced and as our understanding of the procedures have advanced, and as many things have happened, such as, ERAS protocols that make pain less, and all these things have come together to make it so that we saw this. I think Dr. Torrey and I actually came together because of a common vision that we should be able to make these operations somewhat more accessible in smaller community hospital environments. And so that was our mission when we came out. Our real goal was to be able to establish world-class microsurgical care, but be able to deliver it in a place that might be closer to someone's home. It might be able in a more intimate environment where they don't, these big academic places they're amazing for dealing with the esoteric, the things that are very rare and sometimes hard to find. And there's, specialists will be there, sometimes they're operating on cases that are just, in single or double digits, each year. So they're doing these cases, and those are cases where you really want to be in a place that super specializes and has that sort of thing. But breast cancer is very common. And so, and there are a lot of breast cancers that are, thankfully very amenable to treatment now. And so it just seems logical that we should be able to make all the reconstructive options available to people in any environment. And so our mission was really to be able to get out to smaller hospitals and to be able to do really complex microsurgical operations like deep flaps, gap flaps, tugs, PAPs, whatever, all of these operations that can carry tissue from any part of the body pretty much and make a breast with it. And for all intents and purposes, I think we accomplished that for the most part. We do most of our surgery in Columbus, but we're able to get out to places like Dayton. We were in Cincinnati. We get up to Toledo. We get out, pretty much all the way across Ohio. The only part of Ohio we don't really operate in right now is the north east part of Ohio. But otherwise, we really do kind of get out to a lot of places to do these operations, and that was our mission.
Your mission then, but now you have patients come from outside of Ohio.
Yes. Yeah. So now, and I think it's again, because of how things change, travel is easier, and these operations, again, the recovery protocols, we're doing, there are techniques that we're using that are making the operation so much quicker to recover from. We're doing on the inside, sort of under the hood, what's happening. We're not taking any muscle with these operations. We're limiting the fascial incisions so that they're tiny little fascial incisions. The CT angiography that we use has made it possible for us to really be selective and plan the perforators that we incorporate into the tissue so that we can actually really spare damage to any other part of the body when we get these flaps out. And so because of that, and we can, on the chest, a lot of times we're sparing the ribs entirely, in an area where we always had to take some rib. All these things, all these changes have made it so that it's a less painful procedure. It's quicker to recover. The procedure times take less. And so all these things have made it possible. Now people can travel and stay in the city for, a week and get back to their homes and usually kind of do just fine after that.
Right. So what do you normally tell patients when you are having consult with them? One of the things that I get a lot of questions about is pain. And you mentioned ERAS a little bit ago. So talk to us about ERAS. And then if patients are traveling or if they're not, so twofold question here. Talk to us about the pain in ERAS. And then also talk to us about recovery time. Even though patients are getting out of hospital quicker, there's always a period of recovery. So what do you talk to patients in their consult about those two topics?
So, with regard to the ERAS, which is ERAS, and there's a lot of different, it's, expedited recovery after surgery or something, whatever. There's a lot of different ways to break the acronym apart. But ERAS basically, in its most simplified form, is really trying to recover from surgery with as little narcotics as possible. And the extreme of that is no narcotics whatsoever. And you can take it even to a level higher, and you can actually do surgery without narcotics these days. So a lot of our outpatient cases, actually almost all of our outpatient cases in the phase 2, the revision operations, those are done in with no narcotics most of the time. And so, but the whole goal is to minimize narcotics and to use other forms of pain control. And those can be simple things like oral medications and sticking to non-narcotic oral medications like long-acting NSAIDs like Celebrex or meloxicam, using other types of medications that can affect the nerve, like gabapentin is one that's pretty commonly used.
Yes.
But then you combine these also with blocks. You can use blocks that are both done for both, for the deep flap, you got two areas to block. You got to block the chest, you got to block the abdomen, right? So both those areas need to have some blockade. And so those blocks can be done by the anesthesia team. They can be done by us during surgery. You can combine your efforts and do some during surgery, after surgery. All these things can be combined in a way to minimize a lot of that acute pain that's going to happen the first few days after surgery. Now, after about 3 to 5 days, that pain is, so we're really focused on trying to cut down the pain the first few days, because about day 3 or 4, the pain seems to at least really taper off. And we see that because a lot of people in general don't need narcotics after about 4 or 5 days. They really are able to come off of them slowly. But these days we try to get them off of narcotics right away and try to manage with just Tylenol, ibuprofen, or longer acting medications. Now, these types of pain control regimens, which have minimized narcotic, and also minimizing narcotics is key because it gets you moving faster, gets the patient up moving faster, gets the bowels working faster, gets everything happening faster. And so that expedites recovery just because they're not on a narcotic. And I think, in the present day, with so much concern around narcotic addiction and the attention around trying to, be very cautious about narcotics, it just makes sense that this all this has evolved as it has right now. But it has all come together nicely to make, this operation, which was once a pretty tough operation to recover from, now pretty easy to recover from. When we see our patients routinely, we do deep flaps. The average stay for a unilateral deep flap is a day or two after surgery. A bilateral, they might stay 3 days, but we've even done unilaterals in the outpatient 23-hour setting for the right patient. And so, it's possible because of these, again, everything has to come together. And we actually wrote a paper about it recently. It's an interesting little paper about when you take all of these things and you can actually realistically get patients out quickly. And it also requires some technology. We have to be able to monitor the flaps in a way that we know the flaps are going to do okay. So all these things have come together to make it possible to get the patients at least out of the hospital sooner, because once they're out of the hospital, they're in the comfort of their own home. They can actually be more comfortable, get more rest. And for patients who are traveling, obviously, if their pain's controlled and we know our flap is viable, there's really no reason to be sitting in a city far away from your own city for an extended period of time once you're outside that window where we would worry about certain complications.
It's so interesting. I just talked to a woman yesterday. I was counseling her about deep and all the nuances. And she asked me again, I have so many women ask me this about the pain, because you have incisions. You have incisions in the breast. You have a hip bone to hip bone, or maybe in the inner thigh or the back of the buttocks, wherever you take the tissue from, and you think in your mind, incision, this is going to hurt. And so I told her about ERAS, and I sent her some information about it. The first thing she said, "Oh, that sounds all great, but then what happens at day 3? But you just answered the question."
Yeah.
So you've talked about how this breakout pain that you talk about, or this longer lasting pain, you guys have studied that.
Yeah.
And you found that over time, really at day 3, it can be managed with some of the non-narcotic. And getting moving, I have to tell you, from a patient perspective, is so important to healing. As you said, everything has to come together. But when you go to a surgical center like you and Dr. Tawari have, and others across the country, I tell women, if you choose a surgeon who has a very high success rate, all of these things that you just talked to us about are going to very likely, high likelihood of everything falling in place and coming together. Mm-hmm. So that's why it's important to choose a great microsurgeon. So,
I think on the technique side, though, I kind of touched on it, and I can't emphasize how important it is what goes on sort of underneath the hood, on the abdomen side. That scar on the outside is going to look the same no matter what. But what happens on the inside is so important, because the same operation, it looked the same on the outside, but the more we minimize the surgery that has to happen on the muscles, the six-pack muscles, the rectus muscles, the more we minimize the fascial incisions that have to be made. And again, how do we minimize this? Well, we get scans that help us make sure we get the right vessels. And once we know the correct vessels, we can minimize the damage to these, or we can use microsurgical techniques to really minimize the damage to the rectus muscle. We talk about bypassing, vessels or perforators and, dividing them, reconnecting them on top of the muscle. These are super advanced techniques, and we do them really just to avoid injuring the muscle inside. And if we put that effort forward, it comes back. It's so worth it, because what we see on the other end is better recovery, less pain, and patients doing so much better, so much more quickly. And so I think I just can't emphasize what happens inside, but that's the tough part. I wish I could sit here and tell people all day and night, man, I know you want the outside part's great, but it's what happens on the inside that makes such a difference in how this goes.
It is, and I love that term, under the hood. I don't think women realize they have to ask the difference between, those different nuances that you're talking about. I don't think women realize sometimes how much they use that rectus abdominis muscle or sit-up muscle, getting out of bed, rolling off of a medical table, just getting up and down, everyday stuff, even.
It's a core muscle. I mean, it's so critical to stabilizing your core. I mean, that you've got your paraspinous muscles on the other side, but on the front side, it's your rectus muscles and your obliques, and it's doing everything. It's stabilizing your entire core.
Yeah. Talk to me really quickly, because this happened to me after my deep flap. Do you hear women speak a lot about back pain, just maybe in the first week? Because it happened to me, it was taken care of. Speak to us about that.
Yeah, that's pretty common. And there's another common thing is some numbness and some pain in the arms. And actually, it's most likely because of being on a surgical bed for a prolonged period of time and not moving, because you're asleep and you're paralyzed for parts of the surgery. So the body can't move. Normally, you would be even just sitting here, we move. We don't know it, but we adjust things so that we don't put too much pressure in one spot for a long time. And that's why in paralyzed patients, they don't have that sensation to know to react, and then they end up with pressure sores. But in a surgical state, when the patient's asleep, they're in one spot, they're not moving, and they're there for a very long time. So the longer the surgeries are, then we see that that's more of a problem. And so obviously it's more common in people who have bilateral reconstructions. I mean, unilateral operation takes about 3.5 hours these days, but bilateral one, more like probably 6. So and that's that stuff, it's a longer surgery, but if it's even longer than that, it's more likely that you're going to have that stuff, but it usually goes on to get better. We do so much to pad these beds. We've got really fancy padding, gel pads, and then foam, and our nursing staff in the operating room is just so aware of these things. They're very, very good at identifying the areas, and so I think that helps, but there's no way around it. I think after you've had a long operation like that, you're going to be stiff and sore in those areas, and that's why it gets better so quickly.
That's such a great analogy. I mean, when we get up in the morning, what do we want to do? Like
Yeah.
that. But even at night, when we're in bed, we're moving around. Surgery, not so much. So that's really good analogy that you gave on that. I will add that to the blog once we get this video wrapped up, and put that information in the blog. It's really great. So tell us, real briefly, I mean, this has been a great conversation. There's been so much valuable information that you've put into this video, Dr. Kocak. How do patients, if they're looking to find someone in the Ohio area or not, tell us how we can find you.
I mean, I think the first thing is if someone's interested in a microsurgical breast reconstruction, there are a lot of options these days, which is good. But I think it's very important. I think microsurgical training is important. It certainly made a huge difference for me. So speaking anecdotally for myself, I could say that microsurgical training is important. It's a time where you focus an entire year on only doing microsurgical procedures, and you start to refine the techniques that you use in the operating room to not just put the vessels together, but to really learn which vessels to select, how to design flaps. So I think microsurgical fellowship training is important. I think that obviously someone should look for board certified plastic surgeons, certified by the American Board of Plastic Surgery, because that process is such a stringent process out the gates. I think it selects people and makes it clear that there are level of training, and that they do the vetting for the patient in that setting.
Right.
But microsurgical fellowship training is important. And then a lot of times we talk about volume in terms of cases. How many cases do you do? Well, I could tell you I do 1,000. I could tell you I do 10, and it'd be me just telling you. We could always hope someone's honest. I actually do 275 deep flaps a year. So, but how do we know? So that's a tough one, right? So I think it's important to ask, but I think it's very important for the patient to look at the group or surgeon they're trying to go see, and look at what they're spending their time and energy on. So, I mean, I have very limited time to do things outside of surgery, except for the last month. But up to that point, we operate from 7:30, 7 a.m. until, sometimes 5, 6 in the evening, we're getting done with things. We'll do a deep flap and sometimes 1 or 2 more cases. And so by the time I get out of the operating room, it's after 5 o'clock a lot of days. And so if I'm going to do anything else that day, it's usually we sit down and we try to create content around microsurgical breast reconstruction. We try to answer questions about microsurgical breast reconstruction. We dedicate a lot of energy and effort. We write our papers about microsurgical breast reconstruction. And that's because it's truly the area of our interest. I mean, my practice genuinely focuses largely on that. About, I'd say, over 80% of our practice, at least, is entirely microsurgical breast reconstruction. So I think for the patient, I think it's good to ask questions, but I think that it's also important to try to answer those questions themselves. And so they should dig deep. And the internet's a great way to start to see what people are doing. So if I have a website that's full of other photos or something like that, I'm doing a lot of other stuff, which is fine. It's totally fine. But for the patient, they have to find a person that they're comfortable with and want to go with. So don't think that the first person you see has to be the last. You should also look at your other options. And I think a patient should always find a surgeon or a group of surgeons that they're very comfortable with. It's really important because this isn't sort of a one and done thing. A lot of times there's the potential for small things or complications that have to be dealt with. And you might have a long journey together. Sometimes it's, 3, 6, 9 months of working together to get a result that everyone's happy with. And I think the patient has to have a good relationship with their doctor in order for that to happen.
Oh, I do too. And I know that you guys also practice a shared decision-making model. I've talked to Dr. Tawari about this in a video that we did at one of the conferences. And that is, to me, what builds trust between the patient and the surgeon.
Absolutely. Yeah. And I know you've put so much energy and effort into the shared decision process as the patient advocate, and that's fantastic. So that's hats off to the efforts you've put in that area.
Yeah. Well, I'd like to do another video with you on another topic. When these videos occur, I learn so much. I think that I've heard it all and I haven't. So let's do another video soon and we can wrap this up today. And again, I'm really sorry about the IG Live. We tried.
No, it's great. So we popped off a little Zoom video. Next time, hopefully I'll get my technology straight, and I'll work with my folks here and see if I can get it to work. And then once we get it up and running, we'll jump on IG Live. This is nice because it's permanent. The IG Live stuff disappears, so this is nice that it's there.
Yeah, and just as a wrap up too, I want to let the viewers know. Please let us know. We've had so much great content today with Dr. Kocak. Please let us know if there are other topics you would like us to cover. Give us a like when you view the video, and please subscribe to our YouTube channel because we will be adding more videos. And let us know if there are other topics that you would like us to talk about, because I love having these doctors on, and great conversation today, Dr. Kocak. So thanks for joining us.
Absolutely my pleasure. Thanks, Terry. And I look forward to getting on a call again soon.
All right. Take care.
Take care.
Bye.